Next up, we have Dr. Natalie Stahl, who's going to talk to us about helping hospitals do less harm. She is at Greater Lawrence Family Health Center.
Hi, maybe does this work? Can people hear me with this? Did I turn this off? Maybe I'll use this. So I'm from Greater Lawrence Family Health Center, and I work at Lawrence General Hospital as well. And the goal of this talk is to kind of talk about some practical strategies and talk more about the experience of our patients when they go to hospitals, and not just like all the details of the medicines, but what are big picture and little picture things we can do so they are less harmful, because we know that hospitals by and large are very harmful to our patients, and many of them come away from them with really bad experiences. I have no disclosures, some background on my experience. So, I trained at Greater Lawrence Family Health Center and Lawrence General Hospital. We had a kind of resident run consult service for a bit over lunchtime when I was there. And then one of my co-residents started my fourth year started a consult service. I went to Yale for addiction medicine fellowship. So I experienced and I stayed there for a year as a full-time attending in the smaller hospital in New Haven. So and now I'm back also part-time. So I've been doing 16 hours a week, like just me on the consult service. I've experienced the community side, like low resource, and then also all the resources, academic consult service. I'm gonna, hopefully this works. Yesterday, Ruth said we heard from too many doctors, and we do hear from too many doctors. They couldn't come with me, but this is Sarah on our right and Ashley on the left. They're two of our amazing recovery coaches. They work on our syringe services program, and they both are in long-term recovery. For both of them, medications were part of that journey. And for both of them, they're like harm reduction heroines. So let's see, it's a little bit long, so bear with me. Let's see if the audio works. It's me asking them questions about their experiences and their patients' experiences in hospitals.
So when I was using, and I would go to the hospital, the first thing I would hear as soon as the doctor walked in is, if you're here for pain meds, you're not going to get any. Whether I was there for an ear infection.
Sorry, I wanted to go back to it started halfway through, so, okay, there we go.
So when I was using, and I would go to the hospital, the first thing I would hear as soon as the doctor walked in is, if you're here for pain meds, you're not going to get any. Whether I was there for an ear infection, whether I was there, for a cut, it didn't matter what I was there for. So that immediately made me feel uncomfortable and judged. People that are using, I'm not saying that sometimes we don't go to the hospital looking for pain meds or whatever, but, I feel like they could have entered, at least asking what I was there for, before automatically judging me for being there. And the same thing now. I find that the same hospitals that I would frequent, when I was actively using, I will still get the same judgment even after 4.5 years, over 4.5 years, in recovery. So also, when you go into the hospital, they usually will do labs. And me being an IV heroin user, I know I have a lot of scar tissue on my arms and that I'm a hard stick. I don't need the person that's coming in to draw my lab saying, oh, wow, you have a lot of scar tissue. Why do you have so much scar tissue? We both know why. They've read my chart. We all know why I have it. So those are a few things that I would recommend, not doing, and just show compassion. Compassion for the person in front of you, What about you?
For me, I would say there is no difference of how poorly I was treated when I went to the hospital when I was using, as opposed to when I go to the hospital now being in recovery. Having kidney issues, mainly more so when I was using, you walk in and it's automatic stigma. No pain meds. They treat you completely differently. through my pregnancy, I was on methadone in recovery, and the way that I was treated at the hospital was less than human. I don't know. But I try to not go to the hospital because whether I'm using, whether I'm in recovery, it doesn't matter. I'm still treated the same way. Which is why my people, when coming from me, I'm like, oh, babe, you got to go to the hospital. That looks bad. Or you have a fever. I understand them not wanting to go. I still don't want to go. So I would like to see a lot of things change to make people more comfortable. So with my people who go to the hospital for abscesses or skin lesions, wounds, getting told, well, you have to stop using drugs. You shouldn't be injecting in the wound, but you have to stop using drugs. You don't think that they know that? You don't think that we all know that? None of us rolled over one day and woke up and said, I want to be a raging heroin addict and really mess my body up. But that's what some people think that it is, and that's how we're treated.
I think some of the physicians in the emergency rooms, they still see it as a choice, you know, but, the only way you're going to get better is to stop using. You just need to choose not to do that. And if it was that easy, you know, Ashley and I would be out of work. Mm-hmm. You know, it's not that simple. And, you know, it's a physical dependence, a mental dependence, and it takes time, so.
And it sounds like in a lot of your experiences and also the experiences of people, like people are told that, but not actually given any help to like, oh, by the way, maybe you should stop injecting.
I was never once offered any type of resources. When I chose to get into the methadone clinic, I had no idea about methadone, Suboxone, MAT in general. I had no education on it. Had I had known what I know now, I would have done things a little differently. But I had no guidance. I had no idea what I was doing. And then getting pregnant 3 months into the methadone clinic, I was petrified and still was not offered resources or support from the doctors at the hospital.
Yeah, I agree with that. Up until I went to Mass General. When I went to Mass General, that was a good experience. I had, I met, I met with an addiction specialist who was I started using when I was 19. I think I was 40 when I went to Mass General, a little over 40. And that was the first time that a doctor ever talked to me about Suboxone, methadone, ever gave me the resources. There's a way that, you know, you can stop using and not be in withdrawal, and we can make this as painless as possible for you. And not only did he educate me about it, but he educated my family about it, which was a big thing. So, just giving patients the education, explaining how the medications work, explaining that you're not substituting one drug for another. There's a way to start these medications and then stop them if that's what you choose to do, and do that without the withdrawal and the pain. So
Day to day.
Absolutely. I think that every hospital, from emergency room to admissions, should have a recovery coach. They should have a peer, someone that they can talk to who's been through a similar path, who can understand it, and there's no judgment, and who can help advocate for them and explain their personal experiences. I love working with the population that I work with because I'm able to talk about my experience with methadone, with Suboxone, and with Sublocade. And it's so much easier to talk to somebody who understands and who's done it, as opposed to somebody who is just going off of what they read somewhere.
Yeah, I feel like patients are going to feel less judged by talking to a peer, somebody who's been through it. And you know, I agree with Ashley that they need to have the recovery coaches in the hospital. You know, somebody that will advocate for them and say, you know, sometimes I think we find when we're actively using, it's hard for us to explain to a doctor, because you know, we see them as up here and us as down here. We see that automatically. It's just we don't feel good about the fact that we're using every day. We know that people, or we feel that people are judging us, and I think just having somebody there to maybe explain, you know, how we're feeling to the doctor, somebody that doesn't, somebody that understands, you know, maybe will make that transition easier. Right, and you and I have talked about this before, but you know, they already have a substance use disorder. You're not going to give them another one. If they need pain medication, you know, give them the pain medication. And you know, if they're staying and getting the medical care that they need, the pain medication is not going to hurt them. My opinion.
And if I remember correctly, Sarah, your recovery started in the hospital.
My recovery started in the hospital with that addiction specialist who spoke to me about the Suboxone. They started me on it. They educated my family on it, that this was not substituting one drug for another. And I went from Suboxone to Sublocade to recovery coaching. So yes, it did. So just having that one person there to say that, you know, we can fix this. We can help you, you know, do all the things that you want to do. Get back to being the person that you were, and no judgment, no stigma, and then supporting you through it. So
Sarah is like the proof of what can happen when you are in a hospital, when you're treated and educated. She's got over 4 years now?
almost 5.
Almost 5 years
Coming up
now.
on 5 years. Because of that one doctor who took the time to come in, sit down with me and my family and say, you know, this is a disease. This is not a choice. She's not choosing to do these things, you know, and there's a way out. You know, there's medications that can help her return to the person she was, you know, before all of this. So I am grateful. I am grateful for that doctor that took the time to sit down and do that for me and my family and my children.
As a person who's actively using, walking through any door, whether it's the hospital doors, a syringe service program, a detox, it takes so much energy, and it's so scary because we have been treated a certain way and we're used to that. And people are always like, well, why don't you ask for help? The reason why is because we ask for help, but we're not given the help that we needed, or we're treated a certain way. We're treated less than. So for somebody to walk through any type of door seeking help, they need to be treated with respect and dignity and given resources and be educated, and they just, it needs to change. It really does need to change.
So thanks. So that's long, but that's our major work. So I'm very grateful for them for taking the time to do that. And so this is not, I am not an absolute expert. A lot of this is me bringing resources of things that have occurred to me, things I've been taught, and resources. This will show up a lot. I'll give it to you at the end. And there's a bit LI, but I have a Google Docs that has a lot of PDFs of the papers that I'm going to briefly refer to back you up when someone tells you, you can't give this person oxycodone for withdrawal, but you can. So citations help sometimes. So I'm going to kind of go through the hospital stay. So for a lot of people, making the hospital as comfortable starts before they come or in the ED. Sarah and Ashley talked about how the first impressions really matter, the ED really matters. So I think as much as possible, having a warm handoff or a plan, just make sure that people have a sympathetic ear or an order for methadone as soon as possible is important. And this really depends on your system and your structure. Like I work with, like right now I have a system where Ashley, I work on mobile health unit. So like half my job is outpatient, half my job is inpatient. So a lot of the patients know me already, but if I'm in the hospital, you know, Ashley can text me and say, can you look for this person? And I can go find them. But I'm not always in the hospital, so it doesn't work 100%, but we have residents who are in the hospital 24/7, who are often the people admitting them. And we have a culture where like the ED knows their Greater Lawrence patient will call, so the residents to say, is there anything I should know about this person? So if I'm seeing someone and like late on a Wednesday night in the mobile unit, I'll give them my card with my number on it. I'll say like consult addiction medicine. If overnight, call the residents for interim recommendations, and that's the fastest way for me to make sure they get some kind of support right in front of them. At Yale, it was different. We were there full time. I had Epic. If someone called ahead, we had our own curated list. It was kind of easy in the EMR. We added someone to our consult list ahead of time. So as soon as if they crossed, if and when we knew a high-risk person was supposed to come to the hospital, like once they popped up with a room or they were in the ED, we'd trot over there to make sure we figured out who was taking care of them, or we could text. So it really depends on the system, but find a way to make sure that someone has a sympathetic, voice as soon as possible. And also, what's the first thing they hear from your mouth? People come to these drugs, they come to the hospital for medical care, not for an abstinence lecture, and often they just get an abstinence lecture first. So when I introduce myself, I say, especially someone who is in withdrawal, uses opioids, I say I'm from addiction medicine, and first and foremost, I'm here to make sure that your pain and withdrawal are treated so that you can get the medical care you need and deserve. And that is the first reason I'm there. And then if you're interested in stopping use or using less or using more safely, I'm here to help with any of those goals. And I like to say all those three in the row. Open-ended questions are great, but an open-ended question that says, how do you feel about stopping? Or how do you feel about your substance use? Like, that's a leading question. Let them know if you're harm reduction is part of what you want to do, say that so they know they can answer you. And then ask permission to ask them questions about their substance use. And then during the stay, most of the interventions are obviously during the stay. Part of this is the medication and the orders. And this is, a large topic. The most important thing, assertively treat opioid withdrawal and pain, fill the opioid receptors. This has a lot of parts. We talked yesterday in the methadone course about dose confirmations, like why is it so hard? But what's the protocol in your hospital? In my community hospital, there's 2 main methadone clinics that are nearby. The pharmacy dose confirms first thing in the morning, so they kind of do everyone at once. It actually works really well. When I got to Yale and it was like the responsibility of maybe residents to do while they were rounding, I was like, what? She's like, how does this, like, that doesn't work. Like, so what's the system by which you ask for those confirmations? Methadone clinics are required to have a process to be reached 24 hours for like after hours emergencies. When you need to get a dose confirmation later in the day, you should be able to. Our SOTA says if you do not have success in reaching them and getting a number, let them know. Like there's very few methadone providers, who are responsible for a large number of our patients. They can pay someone to answer the phone. They get paid already to take care of our patients. Let's hold them accountable. Faster methadone titration. There are a lot of hospitals that still only give 20 or 40, or say we can't get above 40 if someone's not already on methadone. That is a myth. There are no rules about that. You can absolutely go higher than 40. But the things that Mass Gen was doing, that Evan Gale talked about yesterday, the really rapid titrations, I can't do that in my hospital because I am there 16 hours. If I'm there 16 hours a week, I am not there to see the patient at the peak dose. But I think for most hospitals, something like 30 plus 10 day 1, or like 40 plus 10 day 2, 50 plus 10 day 3, holding people at least at 60 or 70 is really reasonable. There's a great Things We Do for No Reason. You guys know that Things We Do for No Reason series that Marlene Martin, Honora Englander did earlier this year about methadone. We should be throwing that in all the hospitalist rooms. There's an Adapting Methadone in the Fentanyl Era by Zoe Weinstein and others. There's the new paper from MassGen that just came out. So faster methadone titration. Bupe, not stopping it unnecessarily. That still happens for surgeries. There's also a Things We Do for No Reason about that. But sometimes you're not sure. Someone comes in like 2 days out, like I like to check a urine bupe to see if it's still positive as like a little bit of reassurance to know if I can restart it and knowing how to restart it. And short-acting opioids, because if you're not fully covering with methadone, if you want to start bupe later, but you can't right now, if people are in pain, you need to be willing to do short-acting opioids to cover either pain or withdrawal. You need to be willing to do them at high doses. Also, people will be told, I still have residents be told by overnight hospitalists, you can't use short-acting opioids for withdrawal. Also a myth, in the hospital you can, and there are two amazing papers to back you up. One by Ashish Thakrar, one by Dr. Wakeman and Dr. Heineman. So it is really appropriate and incredibly helpful to use short-acting opioids for those reasons in the hospital. And I get pushback from hospitalists, and they say, I'm uncomfortable with all these, I'm uncomfortable with this. And I try to say, what makes you uncomfortable? You know, but because all the worst outcomes come from not filling the opioid receptors. Like they already have an opioid use disorder, you're not gonna give them another one. It's highly unlikely that your PO'd hydromorphone is gonna rock their world when they use IV. But even if it did, no one is gonna take away your medical license because you gave someone a moment of euphoria. Like that doesn't happen, right? Like the worst case scenario, if you do not fill the opioid receptor, like, and they have lower tolerance and they leave the hospital and they use the same amount that they used to in this like era of unpredictable and deadly supply, they can die of an overdose. Or if you don't fill the opioid receptors, they might leave the hospital early and not get medical care. From our perspective, either they're going to leave the hospital and go back to use and we want them to not overdose when they do, or they're going to leave the hospital hopefully on a close to therapeutic dose of buprenorphine or methadone, and those opioid receptors are going to be filled. There is no reason to not fill them. So, offering flexibility and choice for how you start those meds. For methadone, how you dose it. Sometimes I ask people like, do you want to hold some more for overnight if we're not at goal yet? You know, for buprenorphine, starting in this era is terrifying for people. It's stressful. The individual experience varies so differently. So like we have so many options. We have high dose starts, we have rapid low dose starts. We have the washout where you give people oxycodone for a few days and then hold it overnight, give them some, diazepam and start the traditional way in the morning. I heard that used to be that's how buprenorphine used to be. I never got to experience the pre-fentanyl buprenorphine starts, but I've done this and it's really lovely to give someone medicine and know you're not going to make them sick. The more you can offer and the more that addiction medicine specialists help hospitals offer, the more that someone who wants to leave on bupe will. And offer flexibility and choice, including for pain medicine. It's not just about being willing to dose enough. I really feel like the way that you put in the orders for the same, MME over the course of the day makes a huge difference in the subjective experience of the patient and also like the relationship between the patient and the nursing and the staff overall. Of course, like schedule the things that aren't opioid meds, but also for people who have a lot of pain or in withdrawal, scheduling the short-acting opioids is often appropriate. It's often needed, and it takes away the what's your pain level, like, or having to ask for it, all that anxiety that Ashley and Sarah spoke about having to ask for it. If you're as needed, every 6 hours, like Q6 is different than QID. Like, is someone watching the clock or not? What if their methadone covers them a little in the morning and they want more in the afternoon? So like think about those kinds of details about how you're putting in orders. Often one order isn't enough. If they're getting PT and it's painful, if they're getting wound changes, you need a separate PRN order. Don't make them time and like save a PRN. Like put in a separate order. It's okay. You just explained in the order what it's for. And then when you're tapering, ask preferences. Like, do you want to space it out? Do you want to decrease the dose? I can never find 5 times per day. It makes me crazy. So I just do 4 times per day and add an extra one. Like sometimes how you put in the orders really matters. Another thing that we are really anxious about is giving people benzos in the hospital, like God forbid. But our patients have incredibly high disproportionate trauma burden. Experiences with being incarcerated in the hospital feels like that. Stigmatizing interactions with nurses. They're less likely to have visitors. They're less likely to be able to reach people they can get for care because they don't have phones. Other people out there don't have phones. Staying in the hospital is very hard. Like And then I think about the nocturnist who gets 30 pages an hour. Like, do you really want your patient to leave the hospital because something bad happened or they had a bad interaction and they have to convince the nurse to page the doctor and the doctor has to decide? If you have a patient who you want to keep in the hospital, who uses drugs, who's at high risk of leaving, having a once a day emergency vent order to me is helpful. I tell people I don't think it should be an everyday thing. And if it is, we'll talk about it. But you can have the PRN order before you need it. It's okay. And nicotine receptors too. Like, oftentimes we assume it's in there. We like anxiety. People are really anxious. They want to go smoke a cigarette, and it's like, but we don't always. If you have more than one pack a day, you should probably have more than one patch on, or at least be offered it. And sometimes it's worth it to have a patient to use things that we normally maybe wouldn't do. This is a great tweet by Dave Munson when he was on the search for some chewing tobacco with the blessing of the inpatient team, because this is you make sure that smoking is not the reason someone leaves the hospital. I will say I'm very unsuccessful in convincing nursing to let me take someone out to smoke, but I try. Avoiding another way that hospital orders can be harmful to our patients. Has anyone had a patient be given naloxone in the hospital or heard of patients being given naloxone and leaving the hospital? So iatrogenic precipitated withdrawal for patients who have opioid dependence it can end a hospitalization. It causes enormous suffering. I've had people ask me, "Oh, they're really sleepy. Should we give them naloxone?" Like, it's not an indication for naloxone. Like, are they breathing? But there's a great article recently that came out from, I think it's not in my group yet, about the Overdose Prevention Center in San Francisco and their use of oxygen. And I think a lot of the overdose prevention and the spot are learning about oxygen, but you're in a hospital, put a pulse ox on them, see if it's okay. If it's a little bit and they're not waking up enough, put oxygen on them. If they are still not waking up and you're worried, give them 0.1 of naloxone every 3 to 5 minutes. If you have a little old lady with a hip fracture who's opioid naive and it's hard to wake up, sure, give her 0.4, give her anything. But for our patients, it's harmful to do that. Okay, and then, so that's all the meds. There's also culture and policy things that affect our patient stay. How we document about patients, how we talk about patients, that does influence how people treat patients. So call out stigmatizing language and try to correct it. Offer support and small human comforts. They talked about the recovery coaches in the hospital. This is my drawer, of goodies. I have those chargers. They have 3 little prongs. They work for any cell phones I can give to patients. Earplugs, earphones. I ask patients if they have a favorite snack or drink. I can bring them to the vending machine. Like, sometimes a Snickers a day, like, really helps. And then stress relievers and things to do. I have fidget toys, those are scratch art, adult scratch art. It's really satisfying. I had a patient who, it was one of those things that would surprise you. He was a Latino guy who struggled a lot with cocaine and he had heart failure, cocaine use disorder, and opioid use disorder. And I asked him and he said he liked Koru, which is like Sudoku, but with adding. And he tried very earnestly to tell me how much fun it was and how it was relaxing. And I was like, I do not find math relaxing. I will bring you some because you can print them out. So those things make a difference. And make the hospital less carceral. We know hospitals are carceral. There's a good article by the UCSF group about especially substance use in the hospital and how we treat it. Like, if we treat pain, withdrawal, and cravings, then so patients don't have to use substances or smoke in the hospital, that makes it a lot less likely that they will. But also, do we give them an opportunity? Like, a lot of people don't have homes. Maybe they didn't necessarily come to the hospital with a place to put their drugs, so like, give them an opportunity to, when you tell them you're going to treat their pain and withdrawal, to lock up their things ahead of time. Minimize visitor and movement restrictions. And when there is concern about in-hospital substance use, instead of just calling security, we should ask them if their pain and withdrawal is treated. We should ask open-ended questions. And just to, I see so many times 2 days after admission, someone was sleepy. We think, let's call security and let's do a talk screen. Like, They were positive for fentanyl when they came in. They are still going to be positive for fentanyl now. Like all that does is add stigma. You know, all that does is make it into a carceral environment. And security should be the last resort, not the first one. So then preparing for discharge, for patients who have a significant medical problem that is gonna need complex treatment like osteomyelitis, I like to have a patient-directed discharge plan or early, discharge plan. Early departures can occur despite best intentions. In addition to all those stressors, if there's going to be like they're cleaning out mass and casts and someone hears that, no, they can't always call someone to go get their stuff. If people don't have the same social supports. So patients will tell me, I'm not going to leave early. And I'll say, that's okay. That's a plan A. That's a great plan A. But let's talk about kind of the minimum amount we want you to stay. And if you stay until we have cultures back, that will help us, give you treatment. If you stay until this happens, that will help us. And I like to say, what's your plan B? What's a pharmacy that we can send things to if you end up leaving early? And I will write up a little paragraph and make a plan. So for MOUD, I'll remind the hospitalist, like, please print the last dose letter. Or in my hospital, we have bup tablets. Not all the hospitalists remember that they can all write prescriptions. So I'll say, please remember, anyone can write a prescription for buprenorphine, must be filmed. You can't just continue the tabs order. The follow-up and an antibiotic plan. Because again, imagine the 2 a.m. hospitalist. You want it to be easy for them. So if this is a little paragraph that's in the primary team's note, not my note, no one's going to read the addiction consult note at 2 in the morning, but the primary team note, like you get called, you don't know this patient. If you put that, then it's more likely that a well-meaning overnight person is going to take care of it. And in terms of the antibiotics, this is another area. A lot of our patients have serious infections, what traditionally got 2 to 4 to 6 to 8 weeks of IV antibiotics. When you're having discussions with patients about discharge planning, when discharge planning is happening, think about alternatives. Challenge ADA violations by skilled nursing facilities. There's going to be a talk about this in a little bit. It might not help the patient in front of you, but we have to try to change it. Maybe patients can go home with a PIC. There's a few great articles, one by Regina Jawa and Alex Wally's team that was like in the COVID era, one by Aisha Appa and Joshua Barkas that was in an NHM evidence of like questioning this idea that any patient with a use disorder history can't go home with a PIC. We're lucky enough to live in the era of once weekly infusions, like dalbavancin, ortavancin. They take prior auth, they take planning, but they are an option for people who have serious infections who can't or go home, stay in the hospital and get the daily IV meds. And then oral antibiotic alternatives for osteo and endocarditis. There's an American Heart Association interdisciplinary paper about endocarditis care for people who inject drugs. That's from last year. It has a table, with all your antibiotic options by bug. A lot of the meds, unfortunately, don't play nicely with methadone. That's a hard part of it. And there's a similar one for osteomyelitis, not especially for people who use drugs, but it's a wiki tool collaborative that came about osteo. But there are options. When people have source control and have had a week or 2 IV antibiotics, the non-inferiority trials are not bad. They're pretty reassuring. So I think talking to patients, I say like some form of antibiotics for 6 weeks is non-negotiable. There are other things in this plan that can be negotiable, and trying to work with them to figure that out. Transition to the preferred plan for MOUD and follow-up. For methadone, having a mechanism for direct admission. We now all could, most of us can't yet practically, but for the DEA, we could give 3 days of methadone to help with transitions. Making last dose letters easy to print, like right next to the work letter, last dose letter, easy to print. And for buprenorphine, if the OTP isn't a possibility, making sure, and people are on methadone during the hospitalization, making sure that we have a plan to offer low dose transitions or microdosing. You used to think you needed 7 days, the traditional protocol. We do not need 7 days. There are protocols that do it in 3. So making sure that you have this as a possibility, like sending bridge scripts, make me crazy when people do not send bridge scripts. If you don't have a follow-up appointment, you can give 2 weeks. There's no 1-week rule for buprenorphine. Send more. And rapid transitions to long-acting bupe if people want. And last but not least, harm reduction discussions and supplies, if possible, at discharge. Talk to patients about safer use strategies. You don't need to be an expert. There's safersubstanceuse.org, which is Yale project. It's better on screens. Next Distro has amazing handouts in English and Spanish. I tell people, I'm not an expert, but I want you to be as safe as possible. Can we go through this? I think people are like they're tickled or, think it's funny when I try to talk to them about rectal use or boofing. Like they think it's really weird that a doctor is doing that. But even if it's not perfect, like you're showing them that you care, and that you want them to be as safe as possible. Warm handoffs to outreach teams. If you have recovery coaches in the hospital, they can put the number, they can say, hey, let's call this person right now so you hear their voice. The overdose prevention helpline has already been given a great plug. I agree. You must listen to the podcast. And I will say, let's put this in your phone right now. Let's do it while you're here. Naloxone delivered to bedside. I think most opioid users have access to naloxone. Our stimulant users who are at high risk of overdose in our contaminated supplies are not offered naloxone. If there's anyone to deliver naloxone to a bedside, it's people who do not go to an SSP regularly. Like if you teach residents, do not let them discharge patients who use stimulants without naloxone and a discussion. And if possible, safer use equipment, fentanyl test strips delivered after discharge. At UCSF, they deliver it at bedside, like after the discharge plan. I can't do that at my hospital yet, but you can prescribe syringes if they can't catch the SSP. You can prescribe syringes for use in Massachusetts. It's allowed. It's going to be a little boat to the SSP. So you can't do all of this. I don't do all of this. It's hard to change systems and overcome stigma and trauma, but and people are still going to leave early sometimes. People are still going to feel like they're treated badly, but trying is important. And so is apologizing directly to our patients when they are mistreated in the hospital. Like say the words and look them in the eyes and say that it was not right and that you're sorry. Show staff how much easier this all is when we're kind, when we treat pain and withdrawal. Send the message that our patients' lives and well-being have worth and that they deserve to be treated with dignity and respect, and make it easier for patients to come back. If you're a trainee or you're getting pushback, point to the published literature. Sometimes it's best to ask permission. Sometimes it's best to ask forgiveness. Like fentanyl test strips, they're not CLIA waivered. Sometimes we can just give them to patients after they're discharged, and we don't need to go through 10 levels of, agonizing over what it means for a hospital to give that to the patient. And just remember that the typical care that people get is awful. So any changes you make are important. And also, if you do not raise any eyebrows, if no one is like, what are you doing? Or if you don't have to have some hard discussions, we're probably not doing our jobs. So that's it.
Good morning. Thank you so much. That was phenomenal. My name's Danielle. I'm a social worker over at the Shattuck Hospital. I am an outpatient, but I work very closely with the inpatient team. One of the biggest challenges is when patients come in and they're identified as an overdose risk. There is no set policy across the state that I can find, or even in the literature. I'm wondering if you could speak to what we should have if we're creating a policy around that.
Yeah, and thank you. So the question for overdose risk, what do we do when someone's identified? So I think, and I have friends who work at the Shattuck, and I know there's a lot of stress, and in the hospital, there's so much stress. So I think that one thing is we should have discussions in the hospital about and education. What is the risk? People feel a liability risk if someone has an overdose, so I think, but saying what are the actual things that we can do, like motion detectors in places and having policies for naloxone or overdose that, like keeping eyes on people and having a policy that's not is going to cause as much harm, actual harm reduction policies across the board. So it's not just like people can't do anything. And if they do overdose, they're given for like 4.4 of IV naloxone. There needs to be harm reduction things in between, things like motion detectors and things like, in Canada, they have safer use sites in hospitals, but we were not going to be there yet quite yet. Should we just...
Hi, I'm Suzanne Smith. I work at Savita, or a series of OBOT clinics in Western Mass. Change is really difficult, but it's possible. We had a patient who was pregnant, extremely stable, on her dose of buprenorphine. Went to the hospital to deliver, required a C-section. When she asked for pain medications after her procedure, she was denied. She was told that her buprenorphine would take care of any pain that she might have. She survived, and we commiserated with her, but our clinical director at the time went to the nurse manager of labor and delivery and said, this has got to stop. Had a meeting. There is now a welcoming meeting with each pregnant patient in labor and delivery before they deliver, where there's a discussion of what to expect, especially as far as DCF is concerned, what we'll do for you, what won't be possible, but this is the facility and we want you to be comfortable here. So our buprenorphine patients who are pregnant are now treated, I think, better than other people who come in to deliver because they know everybody. I'm back, here I am. So it was a terrible story, a dramatic story that had a happy ending. So I just wanted people to know it's worth the effort to try to change things.
Yeah, thanks.
Hi, I'm Emily Regier from Boston Medical Center. This was an awesome presentation. I'm curious, so our consult service has been doing a lot more using short-acting opioids to treat withdrawal, which is awesome. I didn't even know we could do that until this year. But I think that there has been a little bit of pushback and discussion about what sort of the next step or the exit strategy is from that. So I'm curious how you approach that. Are you just doing it for a couple of days while you're titrating someone's methadone? Are you coming up with taper plans? How do you approach that?
Yeah, thanks. I think that it depends a lot on whether if they have a painful thing, especially one that's going to keep them in the hospital. When they have osteomyelitis or something like that, I don't worry as much, and there will need to be a taper plan, but it's going to be down the line. But I think a lot of times I really do think about it as at least until they get to 60 or 70 milligrams of methadone, or we have a plan to get them on buprenorphine. So I think that I will tell patients, I'm sure you know this, but we can't continue this outpatient and stuff like that. Like they know that, so I think that that's often what the anxiety is from the primary team. So I think that I usually consider it, if they don't have a painful thing, I consider it a plan until they either until they're low dose start, like have a low dose start onto bup, or until they're on a decent dose of methadone. And I think for me, at least if they have a painful thing and they're not going to a SNF or something, having a kind of 1 week taper if they're going to leave with meds, like having something that'd be reasonable for that. But it really depends on the situation, and it is a hard issue. Fundamentally, at the moment, you're trying to keep them in the hospital until they have a plan. So and if they have an infection, they don't have source control. If they have like anemia, like I don't care that much until they're stable, and then once they're stable, then I worry about it.
Hi, nice to meet you. My name is also Emily Shea from Mass General Hospital. I'm an addiction medicine fellow there. I think in my experiences this year, it seems like a lot of these interactions kind of turn into more of like an us versus them scenario, which can be very frustrating. Like obviously our intent is to want to include everyone. So I'm just wondering what your practices are, I guess, around like education, informing, or like helping other services, nursing directors, kind of like help see where everyone's coming from to try to provide the best possible care for patients.
Yeah, I think that this is an area where I have a lot of work to do and grow. And I think that I think the most important discussion, I do try to have what are you worried about? Like, this is why I'm not worried about, this is how I think about the opioid receptors with the primary team as much as possible. And I think sometimes me claiming ownership over the plan and clearly in my documentation or putting the orders in really helps them feel less worried about it. But we do need to have, I think, more, especially with nursing, like targeted conversations. People they said, how come they're on methadone if they're still using? I don't get that, because, and I understand that's a hard thing to understand if you don't know much about methadone or how it works. So I think we assume that it's all stigma and judgment, but sometimes it's fundamentally like there's really basic conversations that we haven't gotten to have with nurses. So I think I have goals of, you know, having, like, showing us up at the nursing meetings and having the residents teach too, but I agree. I often feel like I'm addiction consults versus the primary team, and they're frustrated at me for doing whatever the patient wants, and I'm frustrated at them for being judgmental, and it's not helpful.
Like on a bigger level, like I'm lucky to have had some training in like, you know, regulation medicine, racism, bias, stigma in my medical school, but like I don't know if that exists for
Right.
nursing colleagues, and that's something
Right.
that probably should.
Right, and I think that that's part of it too, and I think that but sometimes the short conversation can't include that, you know, so I think figuring out which battles you're gonna fight and like how you're gonna present this particular thing, it's really hard for me. I get riled up. So like, so it's really hard.
Wonderful presentation. Thank you. And I wanted to talk about helping society do less harm. Because in the midst of fentanyl and 100,000 people dying, there's this huge tendency to say, well, let's put people in jail for more years, or let's prosecute them for drug-induced homicide. And I think all of us have to be ready to speak up to stop that kind of harm. There's a real risk of it. I'm done.
Well, and I think speaking to that, like our hospitals, and there's a lot of things in our hospitals and experience of our hospitals that are very carceral, you know, and how do we call the police? What are the policies? What happens if there's drug use in the hospital? You know, whatever we can do to make sure that our hospital stays do not make it more likely for someone to end up incarcerated for substance use is really important.
I thank you so much for your talk. It was fantastic. I wanted to, so I'm an infectious disease doctor and addiction medicine doctor, and founded the clinic in Newton Wellesley Hospital where I do ID and addictions, and I've worked in the Shattuck and in the carceral setting over the years. And I just love your message of education. It's a team approach. There is fantastic data on people that leave AMA with the background in substance use disorder, and it's because their pain needs, their psychiatric needs, and their substance use disorder needs are not met. And we see the data, it's loud and clear. There's also fantastic data on the fact that we can have the same outcomes with 2 weeks of antibiotics and the rest oral. It's the same numbers, they do just as well. And it's an opportunity to engage them further with that oral prescription when they walk out the door. So I love that you brought that up. Thank you so much. And thanks for a great talk.
Thank you.